So, hello and welcome to the first session of the ARMA Working Together conference. I'm Sue Brown and I'm the Chief Executive of the ARMA, which is the Arthritis and Musculoskeletal Alliance. We are an umbrella body bringing together patient groups and professional bodies that work across MSK Health to work for improved services and support for people who experience MSK conditions. So before we get started, I would just like to thank our sponsors who have supported today's event, but they have had no control over the content and the choice of speakers or anything that the speakers say. I'd particularly like to thank our lead sponsor, Pfizer, for their support of our work and our conference. Today's conference was a response to our members' desire to see different MSK professionals working better together. Back in January, I began to seek out people who were already doing this well. I had conversations with some amazing people doing some brilliant work, working to join up services across systems and to bring about excellent multidisciplinary working. It was inspiring to hear about their work, and the agenda for today began to take shape. By March, things were looking very different, and it was uncertain whether we would even be able to hold the conference today. Since then, COVID has thrown a spotlight on the importance of MSK Health in many ways. And through the crisis, amazing work has continued at local and national level across rheumatology, orthopedics, primary, community and pain services. The need to collaborate has never been greater. You will hear about some of this work today, but this is not a conference about COVID. Today is about longer term horizons and how we can continue the innovation in MSK services that was happening before and during the pandemic. I'm delighted at the range of people we have here today. We have delegates who work in every part of the NHS, in private practice, in the voluntary sector, and policymakers, as well as people with lived experience of long-term MSK conditions. And we believe that there is a value in hearing different perspectives, and that by bringing you all together, we will get something that is more than the sum of its parts. It is impossible to overstate the importance of MSK Health. It is fundamental to our ability to move, to be independent, to work, to play, to keep the rest of our bodies healthy. Poor MSK Health has a huge cost to individuals, to the NHS, and to society and the economy. To drive down this cost, we all need excellence in MSK services, better support for people with MSK conditions, and a focus on prevention. We all have something different to contribute to this, and we can only deliver what's needed when we collaborate. I hope you enjoyed today, and I'd like to introduce the chair of our first session, Chris Martey. Chris is an advanced musculoskeletal physiotherapist with a specialist interest in rheumatological conditions, especially AS, and Chris has also recently become a chair of ARMA, a trustee of ARMA.
Thank you, Sue.
Promoted you a little early, perhaps.
Going to say, I think you do a fantastic job, as is. Thank you, and hello and welcome, everyone. I'm delighted to be here today at the ARMA Multidisciplinary MSK Health Conference. I think it's fantastic looking at the lineup and the mix of speakers that we have today. I'm also excited, like Sue has said, to be chairing this first session. We have 3 speakers. You'll have seen this on your agenda. 3 speakers which will all have a Q&A, a question and answer session afterwards. So please do use the chat function. You'll see I tried to say hello and welcome to everyone. Please do put your name down there. Use the chat, use the Q&A questions. They can also be upvoted. So if you see somebody's question that you like, you can also like their question, which will be upvoted to make sure myself or whoever else is asking the questions doesn't miss those really pertinent questions. So please do put that in. And like Sue has mentioned, there's going to be a really good networking area and exhibition area. So obviously this is recorded, but those sections will not be accessible afterwards. So please do take the time to visit those and communicate on there. So we are going to start very promptly in a few minutes ahead of schedule, which is always the right way to go, I think. And I can see our first speaker there smiling and ready to go. So up first, we have our opening keynote from Mr. Andrew Bennett. Now, Andrew, I'm really looking forward to this talk in particular. He's a National Clinical Director for Musculoskeletal at NHS England. And he's also a consultant physiotherapist. So without further ado, please, Andrew, can you share the slides and begin the presentation?
Thanks, Chris. My first challenge on this Monday morning is to share the screen. So let's just see if that works. Just bear with me. Can we see that okay?
Yes, we can.
And shall I do it on slideshow?
Yeah.
Let's have a go. How's that?
That looks brilliant. Brilliant.
Fantastic. Always good to have an extra couple of minutes. I've got quite a lot that I want to cram in. So look, it was an absolute pleasure to have the opportunity to speak at this conference this morning. I can remember the conversations that we had, Sue and I had, in a small coffee house in London in sort of January, February time. Little did we know what was coming. I'm going to reflect a little on that. But also, I'm going to briefly go through the sort of vision and aim that new to the role of National Clinical Director back in earlier this year, we were bringing together. And then a bit of a narrative of our experience during COVID, and use that to inform the challenges we have and the opportunities we have moving forward in the future. So pre-COVID, we put together this vision, and this vision is to promote lifelong best musculoskeletal health within all communities. Now, what do we mean by that? Well, musculoskeletal health enables physical activity, as Sue alluded to at the start. The ability for us to move and be dexterous and walk and run and all these sorts of things help us grow well, work well, and age well, and essentially live life to the full. And we have a massive role in MSK to enable that ability to be physically active. And that, of course, brings significant benefits, not only for MSK Health, but for all cause health. We know that by being active, we can help not only treat, but prevent a wide range of other health conditions. We also know that there is a widening gap of health inequalities. And that is also the case in MSK. So what we want to do as an MSK community is to promote lifelong best musculoskeletal health within all communities. And how do we want to do that? Well, we want to sustain the delivery of evidence-informed, personalised, high-quality healthcare value to all. And there's a lot of long-term plan buzzwords, I think, in there. I think it's fair to say. By evidence-informed, what we do needs to inform research, but research needs to inform what we do. And we need to integrate research evidence with the experience of expert clinicians and the expertise of people with lived experience to drive forward our provision. We want to deliver a personalised healthcare system where people have choice and control of what matters to them. And that involves merging that clinical expertise with patient expertise through to shared decision-making. And I wholeheartedly believe that helps us get the best outcomes. We want to deliver high quality. And if we relate that to the NHS Constitution, that means that care is safe, it's effective and associated with positive experience. And then we want to deliver high value healthcare. We talk a lot about value healthcare. And I think often we talk about the economic value. You know, we can't be naive to the challenges we had even pre-COVID, where our demand was increasing and our resources in terms of financial resources, buildings, IT resources, human resources were constrained. And we can't underestimate the challenges we have regarding economic value. but also I want to focus on social value. If we are going to deliver healthcare, high quality healthcare to all communities across the life course, that healthcare has to be valued by all. And we want everybody engaged in that process, whether it's clinicians or whether it's those with lived experience, commissioners, policymakers, to share this vision and aim of delivering at the highest quality. And of course, there is the environmental value. And I think that's polarized a little bit in COVID. And one of the reasons why we're here, we all haven't traveled to get to a conference. And the NHS has an ambition to significantly reduce its carbon footprint, and we need to think of that as well. So how do we deliver that? Well, this is an example of an MSK delivery framework. We need to build our delivery on the principles, the biopsychosocial principles that drive MSK conditions. To achieve this aim and vision, we need to have integration and alignment across the MSK delivery model, so between primary, community, secondary and tertiary care. But we also need to align with the principles of triple integration and align with and work closely with our colleagues in social care and also within the third sector. And the idea is that we can all share that vision of enabling physical activity to help people grow well, work well and age well. And that really, I've mentioned personalised care already, but that really aligns with the comprehensive personalised care model. They both drive a whole age, whole population approach to healthcare. And the MSK framework provides a delivery structure to enable this personalised approach. It reflects our ambition within MSK and NHS England Improvement to have shared decision-making, social prescribing, and enabling choice at the heart of MSK delivery. And what we want to do is support people to maintain good health and good MSK health, to make informed decisions when MSK health changes, but also to help people live well with MSK conditions that should they occur. And so there is a huge synergy between our delivery framework and the personalised care model that we've developed out of NHS England and NHS Improvement. Now, this was all brought together pre-COVID, and I can remember presenting this at a number of different events. And then coronavirus arrived, and I think it's affected everybody, and it's been and continues to be a roller coaster ride. We in NHS England moved into a sort of level 4 incident response, and from an MSK perspective, we had 3 main objectives. One was to support surge capacity to manage COVID-19 patients. 2 was to maintain urgent and emergency MSK provision. Whilst our services were constrained, we still needed to ensure that those people that presented with urgent and emergency MSK conditions, cauda equina, inflammatory arthritis, giant cell arteritis, still got into the system when the challenges were occurring. And we wanted to reduce COVID-19 transmission. And we rapidly convened a strategy where we brought together a group of key stakeholders in MSK. This included the BOA, the British Orthopaedic Association, and I notice there's some members of this group on this call, but also the British Society of Rheumatology, the Chartered Society of Physio, versus Arthritis, and we worked very closely with ARMA. We also work closely with colleagues in PHE and HE, and this group has indeed evolved and developed during this ongoing pandemic to include a range of other stakeholders, including colleagues from the RCGP, spinal groups, GIRFT, and specialist commissioning groups. But in its infancy, this group had a few roles really. It was to enable collaboration in a very challenged time. It was to enable us as an MSK community to work together, to share our communication, and to ensure that we didn't make a more complicated situation more complicated by not aligning our messaging. But it was also to help facilitate collaboration in a sort of a task and finish role. And what we did is we took the objectives of maintaining a surge capacity, urgent emergency provision, and reducing transmission, and applied this to a framework of delivery. And what we wanted to do as a group is ensure that the messaging and the work we put out in different parts of the MSK framework aligned so we didn't create a more confusing picture. So for example, we put out a suite of specialist guidance documents to help secondary care plan for the pandemic in trauma orthopedics, rheumatology and spine. What we did with this group is make sure that aligned with the messages we were putting out in primary and community care, such as the community prioritization guidance and the primary care SOP. So the message, so the direction of travel synergized to maintain that pathway and that ambition to deliver the highest quality care whilst in a really challenging environment. And another good example of that was the urgent and emergency specialist guidance. As a speciality, we were, I think, the only speciality that pitched specialist guidance more at primary and community care. And the idea of that was to make sure that we still recognised and got the right patients into the system. And that linked with the messaging in the T&O and the rheumatology specialist guidance. As we moved out of the first phase of the pandemic, I think things got more complicated, and I think things are more complicated now. We moved out of a level 4 incident level, and our objectives changed. We still have the challenge of balancing response and restoration in the COVID context. The relative pause to planned care provision has had a significant impact, which will, I am sure, be talked about later in this conference. Right across primary, community and secondary care, colleagues took on different roles, services were changed, and we've had a revolution in how we deliver services virtually. But of course, we now have to respond again to a second wave, and this creates a significant challenge because we need to rebuild services, but we also need to respond. Now, of course, this has all happened very quickly, and prior to COVID, we had the long-term plan, and we still have the challenges that existed prior to COVID. And so we are also legacy planning to account for the impact of the pandemic, to account for the new challenges, but also the new opportunities to try and rebuild and restore services in a better way, not reflecting the ambitions of the long-term plan. And as part of that, we need to evaluate the beneficial changes that have occurred rapidly as a result of the pandemic and see if we can bring those beneficial changes into our service provision, aligned with our vision and aim of delivering the highest quality, high value care. And so this challenge can be broken down into response, restoration, legacy, and beneficial changes. And what we want to do is we want to align those challenges with this delivery framework and the concept of triple integration and enabling lifelong MSK health within all communities. And that challenge is built on managing risk, demand, capacity, and essentially productivity, and to try and maximize our ability to deliver our services within the constraints of infection control challenges we have currently. And so if we think of the future, but the relative immediacy, we've got a long-standing challenge with regard to heterogeneity in MSK provision. We know that across the country, there is variance in how we deliver MSK services right across the framework. MSK provision is complex, and there is a degree of unwarranted variation in commissioning, access, and delivery. And services exist across sectors, they involve multiple professions, and they're delivered across a range of providers. In some areas, provision is fragmented. In other areas, provision is synergistic and works very well. We also have a challenged MSK system, even before COVID, with demographic changes and changes in behaviour, and we had rising demand, we had constrained resources, and we had increasing complexity. And what this brings is inequalities in MSK health. And in a way, we need to accept that heterogeneity. There is population variance. How we deliver MSK services has to vary from place to place because the needs of populations vary. But what it can yield is heterogeneity in outcomes. And we can't accept that. And so one of our significant challenges is to balance that heterogeneity in service delivery with achieving homogeneity outcomes and limiting inequalities in MSK Health, which existed before the pandemic and will be affected by the pandemic. Now, of course, we've got significant challenges with the impact of the pandemic, which we couldn't have predicted last year. We've got a challenge around post-COVID syndrome, which we are learning about currently, but MSK symptoms form part of this. And we have a number of patients who will have had existing symptoms, which then will have been affected as a consequence of COVID. We know that fatigue, aches and pains, and stress, and all these challenges are associated with MSK conditions, which is unsurprising because we know MSK conditions are driven by multiple factors across a biopsychosocial framework that's unique to the individual. And we know that the pandemic has affected all of us from physical, biological, and social perspectives. We've had a number of patients, particularly in the rheumatology domain, who have been shielding. We all have been impacted by social isolation, and that is going to affect our MSK Health. You know, the levels of physical activity, our ability to get out and about has changed. Our ability to get vitamin D and get outside has changed. We've had postponed interventions, and I'm sure we will talk about this later, and this has led to increased waits. And taken with the impact of social isolation and shielding, and the wide range of impacts across the biopsychosocial spectrum associated with COVID, this is creating increasing complexity. And this is all resulting in the potential for widening health inequalities. So what are we trying to do? Well, right now, we are in the midst of the second wave of the pandemic, and we're trying to balance that with, where possible, restoring services. So our strategy, which is underpinning this vision and this aim, is to split MSK conditions into sort of 5 domains: health, prevention, health promotion, assessment and triage, long-term condition management, rehabilitation, diagnostics, and planned care. And there is a wide range of work going across those domains within the current context to help balance the response and the restoration to COVID, whilst balancing the challenges with regard to risk, managing demand into a saturated system that's already more complicated, maximizing capacity within the constraints of infection control, and ultimately trying to make our service provision as productive as possible so we can deal with this sort of bilateral challenge of response and restoration. But then we think about the legacy, and we've got documents such as the long-term plan, GIRF reports. There's a recent report come out with radiology. We've got the excellent reports regarding TNO, and we've got a forthcoming report regarding rheumatology. NICE guidance, and we've got the NICE guidance coming out soon for chronic primary pain. And of course, we've got the Richards reports, which came out a couple of months ago looking at diagnostics and had a significant section with regard to MSK. And that leads us to a sort of number of objectives, but also I think it's fair to say ambitions with regard to legacy planning. Integrating first contact practice into an MSK framework and making sure that first contact practitioners are supported not to work in a siloed way, but within that framework for MSK delivery across primary, community care, secondary care, working closely with the third sector and social health provision, and also aligning with the excellent work that Health Education England are doing around the capability framework. We've got a piece of work regarding long-term condition management and rehabilitation, and I've not put it there, but prehabilitation. We've got the NICE guidance coming out soon, and we've got direction from rheumatology guidance about how we can best manage people, best support people to live with long-term conditions. And I think we need to very much focus on that, both in the context of the long-term plan, but also in the context of the pandemic. We've also got objectives / ambitions regarding medicines optimization, trying to reduce our reliance on opiates, but also long-term use of non-steroidals in non-inflammatory pain. Diagnostic optimization, how can we best make use of our very challenged diagnostic system to support MSK decision-making. Referral optimization, we've got a secondary care service that's been significantly challenged by the pandemic, and we more than ever need to make sure we're getting the right patients in at the right time and maximizing secondary care productivity. We've got to reduce avoidable outpatients appointments. We've got a constrained outpatient system. We do have significant opportunities here, and we have opportunities to embrace the sort of virtual revolution in healthcare that we've had over the last few months to do that differently. And then also audit and evaluation. We need to drive what we're doing by analysis of the data and evaluating our provision. And I think there is heterogeneity how we do that, certainly in primary and community care. In secondary care, we've got the inflammatory arthritis audit and we've got the national joint registries. And although there's challenges with those, it does give us good information. In primary and community care, I'd suggest that gaining that information to drive what we do is more challenging. And we need to, there's a big piece of work looking at how we can improve that. And there's various key products which will support that. We put out on the NHS Futures site a few months ago, primary and community restoration principles, and we're looking to publish an update to that further to help support primary and community care work in an integrated way with secondary care to deal with the challenges described. Tim Briggs and Gerft are working, doing some fantastic work around pathways for specific conditions. And we can utilise them to work within our framework, and we can use our framework to provide the structure for those pathways to handle. There is, of course, the clinical prioritization and validation work, which we published a few months ago to help make decision-making, to support decision-making for those people who have had a pause to their planned procedures. We've got the rheumatology rapid NICE guidance, which is currently being updated in the context of the pandemic. And of course, we've got the steroid guidance, which was published on the BSR website last week. And so those are certain key products which support the here and now, but also in line with the long-term plan, are going to help drive those legacy ambitions that I alluded to earlier. Now, I'm ever the optimist. We talk quite a lot about challenges, but you know, there are, out of this pandemic, I think there are huge opportunities. And I'm not going to go into depth. I said to Sue that I will not go into depth with this because it's been a bit of a passion of mine, but we're presenting on it later. But of course, many of you may know about our Change Challenge crowdsourcing project, where what we've had the unique opportunity to do in MSK is utilise the web resource to go out to the MSK community to try and identify what ideas and innovations have been rapidly introduced into practice and take the principles for those to share with colleagues elsewhere to help form local restoration. And I urge everybody, if they have 5 minutes, if they've not yet done so, to go and have a look at this website. There are some great ideas that have been posted that local services have done, where the principles of which could be very useful in future planning. We've also done a lot of co-production has been at the heart of our work of the last 9 months. And what's evolved, I think initially, well, through our vision and aim and our ambition to drive social value, we've taken a very much approach that we have to work closely with those with lived experience. Quoting Sue in one of her blogs, if it doesn't work for patients, it doesn't work. And this has evolved during the COVID process. It came very clear sort of towards the end of phase 1, that we need to really know what themes were coming through patient helplines and patient resources through our various stakeholders. And so working with Versus Arthritis, but also through ARMA with a number of other charitable organisations, we pulled together the themes of what people were saying during that phase, and especially people who were impacted by shielding, to try and formulate a document to share to inform our policy and work. And that's led to some great work around lived experience and the development of a lived experience group, which is helping to drive our strategic planning, which I'm sure Cristina will allude to. And so what this has led to is the development and the evolution of an MSK network, which I hope can drive forward this aim and vision with an aim to reduce unwanted variation in delivery and enable local leaders to deliver what, best MSK care So we have a lived experience group that is evolved and developing at a national level. We have this MSK stakeholder group, which is still very functional and is meeting at a weekly occurrence. And it's wonderful to be working as a wide-ranging MSK stakeholder group in this collaborative fashion. And then in NHS England and Improvement, we've got this snappily challenged MSK Transformation Delivery Group, where we're trying to take these domains of MSK planning and try and formulate a network and a structure through the regions to enable colleagues in integrated care systems to collaborate with the PCNs and providers to try and drive this forward. And on that note, I will leave you with this quote, which I think is very apt in our sort of future evolution. I haven't been able to say what I think MSK is going to look like in 10 years' time or in 5 years' time. I think we've had this significant event that is COVID that we've got to evolve with, accepting that the challenges we had previous to the pandemic are still there, and if anything have been magnified. And I think what we need to take is that we need to take the beneficial changes we have and this system-based ethos to collaborate, to build, further develop MSK provision to maximise the quality and value we provide for all. And on that note, I've seen Chris's hand twice, so I think I should probably finish. So whistle stop tour.
Thank you very much, Andrew. That was fantastic, and I'm sure people will be clapping with muted applause. But that was fantastic, Andrew, and really great to see you talk system-wide, really, about the areas that really affect MSK Health. Particularly interesting for me to hear you describe the comprehensive personalised care model as well. We do have some questions, and you've finished perfectly on time. It's 10:05. We have 10 minutes before we have our next speaker. So we've got them. We'll just start straight off the bat with the ones which are the most upvoted. And actually the first one here is Colin Wilkinson. And I think this question was posted before you mentioned around co-production. Colin here though mentions that in the MSK COVID response group, he found it disappointing to see that there were no people with lived experience. It added to that perspective, and he was going to say, given what you have said about the importance of that voice, why was or is that? So I think you did allude to a bit more around co-production.
Yeah, sure. So there is now. So when we had to very rapidly bring something together. I think in phase one, over days to a couple of weeks, had to convene a strategy. And I will be brutally honest, I was new to role as NCD, and I had to rapidly learn how this all works. What we did, the strategy was to take the large professional bodies in MSK, and it's difficult because there's so many professional bodies, I couldn't get everybody in a room to function. So then to work really closely with Sue and ARMA, who can provide the conduit for the other professional bodies under ARMA's remit, but also the patients groups, and work closely with Versus Arthritis. So the idea was that would give us a breadth across the professional bodies and the organisation that represent those with lived experience. But working with Cristina and other people through the change challenge process, through the themes of what matters process, and I then learned what resources we had available to enable co-production. And now certainly Cristina sits on this group. We've got representatives. We have the lived experience group, which is a wonderful group to be involved in, where we can channel into the stakeholder group and into the operational delivery work. And so our co-productive approach has evolved as this process has evolved, and to be frank, how my understanding of how it works evolved, and now it's very much embedded in what we're doing.
Brilliant. And I think we clinicians would certainly agree that co-production is vital, and I hear more about that in this section actually. So another question then that's been upvoted is from Quasir Mahmood. They've said, what role do you see the industry playing in collaborative working to help restore, reset and redesign MSK services?
So it's an interesting question.
That's
it depends on what we mean, what we mean by industry.
Mm.
And I won't sidestep it, but I'll take a step back.
Mm.
We are a wide MSK community. MSK is a huge, broad envelope. And as a consequence, there is a wide range of stakeholders, whether that's clinicians, policymakers, those with lived experience, charities, professional organisations, or industry. And what we need to do is we need to collaborate around a vision and an aim, because what we've got in MSK is got loads of great work going on in lots of different places, and we're almost like an orchestra of fantastic musicians. But what we need to do is bring ourselves together as one to God, it's a bit cheesy, but to make that nice sound and collaborate in that sort of way. And so what we're trying to do at the moment, within a really challenging, time for all, is to provide a structure for that. And that's not done yet. I'm not going to sit here and say we've got it right. And also, I'm not going to sit here and say exactly what that's going to look like. That's going to evolve, and it has to evolve. We have to be pragmatic as we go. And working with industry and, pharma and all that sort of jazz is part of that. And we need to bring together. Yeah,
brilliant. No, thank you for that. Okay, well, the next question there is from Ian Bernstein. And I have to say, Ian, there is a little bit of text before your question, so I should quickly go through that. But I think you were saying that here there's differences with the expenditure, for instance, in secondary care versus different areas. He said there's nothing available for triple integration, leveling up community services and prevention. He's asking here, how can you help redress this as your role as NCD, really addressing, it seems, the differences from portion to portion of the system? That's quite a large,
yeah,
but it's had lots of votes.
It's a very valid question, and it goes to the heart of what really the NCD role is. Okay, so my role is to try and advocate for MSK as much as possible within policy making and planning within NHS England improvement, and then work collaboratively with the other arm's length bodies like Department of Health, Social Care and PHE and things like that, with the great colleagues we've got there. And there are lots of other clinical specialities who have got very valid objectives, who are trying to get those funds too. I think what we've done in MSK, and this is a significant beneficial change, which ARMA have played a massive role in, is certainly at a national level, we've come together as stakeholders and loads of lived experience, and shown that when we collaborate and coordinate, we can choreograph a great, a really good bit of work. And I think that's one of our keys moving forward. And it comes back to that orchestra analogy. If we're all playing slightly out of tune, we're not going to sound great. If we're all working together in a collaborative approach, then we're gonna sound better, and thus we can be louder, and then we are more likely to get our sort of slice of the pie that we want. Definitely. So my role is to kind of facilitate a structure to enable that and to advocate. Brilliant.
Thank you, Andy. Last one, I think we can squeeze this one in. So the next voted one was from Barbara Sharp. You will see that there. She's mentioned more about the MSK pathway as a whole and how contracts are delivered really. And she says, will NHS England facilitate new contractual guidance and encourage updating of current contracts?
So, I have to be careful how I answer that and how I commit. I think one of the things we have to look at is how this system works. And in order to drive a different strategy, the nuts and bolts come down to contracts and resources. Yeah. And so we need to evaluate the contract processes and resources we have, aligned with the strategy of NHS England and the Department of Health, Social Care, etc., to try and get us in the best position to balance this challenge we've got with regard to health heterogeneity and delivery, to try and facilitate all the range of providers and those who lived experience and social prescribing resources and everyone to collaborate and work together. So very much involved in engaging in those discussions, and we'll have to see how they go in the sort of new world as we come out of the pandemic.
Brilliant. Okay. I think what we'll do is, and Andy, I mean, I think we could have 30 or 40 more questions. I may see more in, I think, and there's quite a few people mention it. I can see Paul Allen is next up on the voted list. So he says, hi, Andy, you suggest the focus should be to increase physical activity, integrate FCP, those sorts of things. Where does the capacity and capability come from to enable all of this? And where does the focus come from, given most integrated care systems do not include MSK as a priority area of focus?
Okay, so firstly, we need to make sure that MSK is included as a priority area of focus.
Certainly.
And given the global burden of disease that MSK brings, and also our ability to support lots of other, the prevention and the management of lots of other conditions, we need to put ourselves in that position. And so one of the things we're trying to do by having this strategy is to put us in that position. So that's the first thing. Just remind me of the other part of the question before I get lost in my answer.
Yeah, so Paul then said, so that you've answered the second part in a sense. He was saying, where does the capacity and capability come to enable that?
Yeah, and that's a challenge. So it's coming back to the challenges regarding risk, demand, capacity, and making ourselves as productive as possible. And, you know, capacity is constrained, human resource is constrained. We have the estates that we have, what we want to try and do is maximize that capacity by being as productive as possible. Now, there's various ways you can do that, but what we don't want to do is just shift numbers from one place to another without having a strategy to how we're going to do it. So I can't just say, yes, we will, you know, we've got this capacity to produce and whatever. What we've got to try and do is evaluate what we've got now based on the challenges we have and the opportunities that have come out of the pandemic to try and maximize our capacity in a more productive way. Whilst in the sort of medium to long term, we look at, you know, how we are educating, training and developing MSK clinicians.
Yeah, exactly. And that sustainable workforce as well moving forward. So, well, thank you very much, Andrew. That was fantastic. And like I said, lots of questions coming up. But in the interest of time, we will move on to our next speaker. Up next, we have a patient keynote. Okay, so this is from Yulanda Sabrina. She is kindly going to be sharing her story with us today. You may have seen Yulanda already on some of her YouTube videos and on social media presence, but certainly Yulanda will be able to share her screen perhaps and come in from here. So thank you very much, Andrew.
Hi, can you see me?
Yes, we can.
Amazing. I am so honored to be sharing my story and my experience with RA. And I want to give firstly a very big and special thank you to Sue and the whole ARMA team for having me here today. Being offered a platform like this to engage and discuss in this capacity, I feel is vitally important. So thank you so much. I only have a short amount of time, 10 minutes, and then I'll take 5 minutes of questions at the end. But I'm going to try and break down my story into kind of small segments and sort of talk about the various different elements of my experience for a couple of minutes at a time. So I'm going to go through my initial symptoms, to my diagnosis, and then onto my treatments and the subsequent lifestyle changes that I've implemented to help me manage my disease, rheumatoid arthritis. Okay, so I hope to give you an insight into what it's like living with RA, and most importantly, try and explain the best way I can what it actually feels like, because I find that's what a lot of people, you know, really want to know. What does it actually feel like? So if I take you right back to the beginning, give you kind of an overview of my life at the time of diagnosis. I'm a singer, songwriter, and performer. So at the time, this is this is around 2016-ish. I was 27 years old at the time. I'm 33 now. And I was on tour back then with Lily Allen, who's quite a major recording artist. And I'm on tour, everything's fine, but I started to experience pain in my kind of hands upon waking in the mornings. And touring is strenuous, you know, it's hard work. And I thought, you know, maybe it's just a bit of stress or maybe just fatigue of some type. So when I got back to the UK, I saw my GP straight away and I explained how I was experiencing this pain and stiffness in my hands in the morning. And initially she said, you know, it's probably some type of repetitive strain or carpal tunnel syndrome. You'll be fine, she said. Just, you know, take some painkillers, go to the pharmacy and get yourself kind of like some wrist bandages or wrist splints. So I took her advice, but in my gut, I knew something wasn't quite right. I didn't feel that it was what she was saying it was. So I did as I was told anyway, went and bandaged up my wrists and wore the bandages at night and woke up in the morning still with this excruciating pain in my fingers and my wrists. And then after about a week, no exaggeration, my whole body was riddled with pain and stiffness. So from my jaw to my shoulders, elbows, knees, ankles, every joint in my body pretty much was swollen, inflamed, severely painful. Couldn't, you know, getting out of bed, I couldn't stand on my feet. I would have to hobble, you know, to the bathroom. To share more intimate details with you guys, which I feel is important, you know, even going to the loo was difficult at times. And I had to, at the time, I was living with my mum, and I had to ask her one time to help me go use the loo because I couldn't, my hands were not working. So, you know, I kind of soldiered through these initial stages and thought there's really something going on. So I went on Google. I do this often. I diagnose myself on Google a lot of the time, put in my symptoms, and this RA thing came up. And I'm saying RA thing because I'd never heard of it before in my life. I'd heard of obviously arthritis, rheumatoid arthritis. I'm like, what, really? Okay. And the reason why it's rheumatoid arthritis stuck out to me is because of the mirroring effect that the disease has. So, you know, if it's one hand, it'll be the other hand as well. So I thought, okay, I'm going to take this info to my GP and tell her this is what I think I have. So I did that, and still she wasn't convinced. And so I had to actively push her to, refer me. I said, I want to see a rheumatologist. I need to see a rheumatologist. I feel it's this. And she said, okay. So we ended up getting blood work done, and lo and behold, the blood work came back, and, you know, all the markers that they look at were really high for me. So then I was referred to a rheumatologist, and he diagnosed me at that point with RA, which, you know, at 27 was shocking for me because as well, I feel like I had a fairly healthy lifestyle, active, you know, I'm a performer, I'm fit, I'm a singer, I do all this and that and keep myself, you know, fit and healthy and live an active lifestyle. So I thought, you know, and there's this whole stigma around RA being an arthritic conditions in general, being an old person's disease. And so to be 27, it was like, oh my God, really? And then, you know, I felt shocked. You know, I was fearful. I had such anxiety around the whole prospect of having this incurable disease for the rest of my life. The drugs that I was initially prescribed were very, you know, strong drugs, methotrexate, hydroxychloroquine, and then later on prednisolone in the form of tablets and injections. Very quickly, after a couple of months, I began experiencing side effects from these drugs, including, you know, hair loss, weight gain, dizziness, headaches. And I remember having a conversation with my mum, and I was like, if I carry on like this, I feel like I'm going to be in a wheelchair, at the end of the year. I can't carry on like this. So she's very much into her holistic treatments and natural remedies. So she took me to see this specialist, and he put me on a special regime, like a dietary regime. And we stripped everything out of my diet because there's the whole concept of leaky gut and allergies associated with autoimmune disease, things like that. So I was very conscious that as well, I felt like depending on what I was eating would depend on my level of flair. So alcohol, sugar, salt, fried foods, fruit would trigger my symptoms. So we stripped all that out, and then I was on, a clean diet for like 2 months, clean, limited amount of meat and none of the above that I just mentioned. So no sugar, no alcohol, no salt, no anything like that. Symptoms totally eradicated after 2 months. I was a new woman. And I felt marvelous. And I actually wasn't taking any drugs as such in that 2-month period. And I know that's, I'm not advocating that people do that because that's dangerous to come off drugs that you're prescribed, but I felt it was necessary for my story and my experience, and it worked for me. But, life happens, you begin to eat certain things that you maybe shouldn't be eating, and then symptoms come back. So with me, I know for a fact that my RA and the symptoms I experience with my RA are only manageable, in my case, with my diet and my lifestyle. So that brings me on to how things are for me now. Basically, at the moment, so there was a period where my rheumatologist put me on steroid injections for 6 months. Steroid tablets for 6 months. I mean, the disease wasn't it was active, but I wasn't experiencing any symptoms on the steroids, but it wasn't something that I could obviously stay on for a long time. So one of the things that I wanted to mention here today in this conference is that when I was initially diagnosed, I was not made aware that there were, other types of treatments, better treatments that I could potentially try. So, I was put on the methotrexates and hydrochloroquine tablets straight away, until at one of my appointments, my mum came with me, and she said, she'd been doing some research, and she said, I've heard maybe there are these, biological treatments, or is there something we can pay for and all of this? So, my GP kind of looked at us and was like, oh yeah, actually, maybe we can do the injections. And I was really shocked and disappointed because, I'd been through at that point 2 or 3 years of trying to manage it myself with my eating and not really being on any drugs, and then being on heavy steroids. And it's like so unnecessary if I could have tried these biological treatments from before. So I feel I was let down in that area. I'm on these injections now, and I've been on these injections for 2 years, and I take an injection of etanercept every week, and it's helping me manage my disease, and it's been fabulous. Honestly, the best treatment I've tried so far. Really, really great, as well as managing it, being vegan and staying away from things I shouldn't eat. So that's how I'm getting on at the moment. I do experience flares still, and in kind of like conclusion, if I were to use an analogy to explain how I feel the disease behaves, I would refer to it as like almost like a forest fire. So, in one area of the forest, you might get a little spark, but that spark turns into something, major. So that's what a flare-up feels like. You get a bit of a niggle. It might be my wrist. By the end of the day, it's like, full body, I need to get in bed and be in bed for 3 days type of thing. So flares can last from a few hours to a week. sometimes 2 weeks at a time. And it's literally a case of just having to fight through it. The joint pain feels like someone has kind of whacked you on the hand with a hammer. So whacked each finger with a hammer. That's what it feels like, that sore kind of ow feeling. Same with the knees, like someone's whacked you with a hammer. The neck pain is excruciating sometimes in the morning. I don't know if you've ever experienced sleeping on like the pillow a bit funny, or you wake up in the morning and you've got like a stiff neck. That feeling, that stiff neck feeling, can last for weeks, and it's horrendous and very painful. And I'm conscious I don't have a lot of time. I could talk about this all day. I honestly
it's Yulanda, it's brilliant. It really is brilliant to hear this. I do want to make sure we get a question in, but
absolutely,
finished or not, I don't want to cut you short.
That's fine.
No, okay. Well, I think we will in the, we are getting lots of messages in the chat here. Yulanda, thank you for sharing that. I mean, we didn't get too much time to talk before this, but I'm a physiotherapist myself and have a special interest in rheumatology. And I think your powerful story is something that may not be dissimilar to some people who have waited to get a diagnosis. I think what I wanted to pick out from a clinician's point of view, is to hear is that, your GP or the primary care setting, carpal tunnel syndrome, maybe not understanding that could be a precursor symptom that is sort of, masquerading symptoms of a rheumatoid. And I think delays to these conditions, because they can be quite complex, really has a big impact, like you're saying there. And you mentioned as well about the medications, I think I know there's complexities around biologics and the disease modifying drugs that you mentioned, the methotrexate and things. There are certain publications that clinicians follow to try and utilize things in different ways. But like you said, I think it comes around shared decision making, discussions early on with yourself to make sure you're aware of all options that are possible. Because like you said, your mum read into it, you read into it. And I think just because some of these things can be complicated doesn't mean we shouldn't, integrate education straight away.
Definitely.
Patient hand in hand. Yulanda, that was brilliant. And loads of people in the group are saying how fascinating it is. I want to get a question, one here from Sally Pembury. So she said, thank goodness for your lovely ability to share. You are a gift, Yulanda. She's saying, how do you think we help those that cannot and or are too ill or scared to share?
Yeah. I think, societies like NRAS and the charities, the wonderful charities we have in the UK, for instance, they're fabulous platforms and organizations to help you, basically. I'm a member of NRAS only recently, and I get a newsletter every week, and I get a whole information pack every month and stuff like that. And there's numbers to call, there's people to contact, somebody's there, and that's the main thing I would say. Or in terms of helping somebody in that way, because even going to appointments and follow-ups and stuff is quite daunting and quite intimidating, and I think it's very important to have somebody with you, a friend, a family member, your partner, whoever, your child, with you for that moral support, and to ask questions that you might not have thought of, because it's hard enough having to, the mental health side of the disease as well is super, super important to recognize. While you're in those first initial stages of diagnosis, you can't think straight. All you can think of is, how am I going to keep myself alive? How and there's so much going through your head. So to share and to take some of that off of yourself with somebody else, I think is a good thing.
Yulanda, thank you. That is it's so powerful to hear. And I think, again, as a clinician trying to advocate people go to these patient voices, these charities, is so powerful. I think you also answered one of the other questions in there, which was from Barbara Sharp, in terms of how to coordinate this patient voice. And I think, like you said, probably using NRAS, NIS, or whether it's NAS with axial spondyloarthritis. You've hit the nail on the head there. So thank you very much for sharing. We're going to move straight into, you're going to stay with us, which is brilliant. We're going to move straight into our next section, which is from Cristina Serrao, NHS England Lived Experience Ambassador, and really going to talk about exploring a bit what you mentioned here, a bit more around co-production. So thank you very much, Yulanda, and welcome, Cristina.
Hi, and thanks for having me. Wow, whenever I'm hearing somebody else's story and I think, gosh, I remember those days, and it's that kind of that unsettledness, and it kind of gives me a tightness in my stomach, because actually I think it's that mutual understanding that we've had to fight the system, really, when we're fighting our own bodies to kind of just get by and be here today. So thanks for having us. But just very quickly, some people may know I used to be the Camden Musculoskeletal Patient Director based over in Camden. And COVID most definitely has changed things, quite gladly in a positive way. In terms of my own kind of background, I have Ehlers-Danlos syndrome and osteoarthritis, having fallen off a wall 17 years ago. So again, in my 20s, diagnosed with arthritis. And it has been a challenge, without a doubt. I didn't work for 5.5 years, and I kind of went along to an event, and from that I kind of decided, oh, there's this job, patient director, can't do that. Went for it, and then actually it's been a kind of a ripple effect, and it's been amazing. And what's happened now, co-production is alive, and it is probably the first time, I'd say, since the war, but actually the war, we didn't have internet, we didn't know what was happening, but COVID has brought people together, because actually, one, we have been mutual support for each other. I know people talk about digital poverty and exclusion, but what about the inclusion? So I was at home for 5.5 years, sometimes not being able to attend an appointment. I was having panic attacks on the front door to try and leave my house and go to my, therapist, or to go to my, physio appointment, etc. So in those 5 years, I had 5.5 years not working. I had 4 operations. So I absolutely understand and realize that no matter what, what's happened right now is that so many more people will have lived experience. And I really believe in parity of esteem, where physical and mental health is really important as well. And I believe that within MSK services, it's something that we really need to realize that, and it's been so important to be working with Andy. So that what happened was, basically I was joined the experience of care team. I wasn't doing MSK, I was doing quality improvement and co-production work as a patient, and then went for this role a couple of days a week. But actually COVID, it turned around. NHS England contacted UCLH and said, actually, can you release her? The work's got that busy. And it predominantly was because I got invited along by Helen Lee, one of my team, the co-production leads, and said, oh, you did a MSK, would you like to come along? And that element of Andy saying that, yes, they had gone to Versus Arthritis, and they had gone to ARMA and the Royal Osteoporosis Society. But my question to them was, well, what about the people that don't use the helplines? So I'd go onto the internet and I would look up information, but I would never ring up. So I said, what about the people that wouldn't necessarily feel confident enough to pick up the phone, or it just isn't what they would do? So with a bit of convincing, we had an extra weekend to try and get some more voices in, and actually we ended up with 36 pages. And I think that was possibly the tipping point, and a bit more. Andy's been fantastic, and it's been amazing that it's been consistent. So the meetings that he mentions, it started off for me just attending lived experience group, and actually now I attend all 3, or somebody else will attend. And what we built is a lived experience group. So initially it was just me as a lived experience ambassador, having at one point at the hospital 13 consultants. I didn't know I had Ehlers-Danlos syndrome. I knew I was bendy. That was all I knew. And then from that, it was just, we had some representatives come along, and then actually the group's grown to 6 people lived experience. And from that, the challenge stuff came up. I know you're going to talk about it later, but I said, well, why can't we have people lived experience in that? And it was literally just let me just nudge a little bit more. And I'll be honest with you, thank you, Sue, because Sue was my confidant. I was like, what do I do? How do I get into these things? She was like, just ask. So, and gave me that confidence to just ask and see what was possible. And it is that, we say in co-production, it's that element of being uncomfortable. I mean, being comfortable with the uncomfortable. And each time I come to one of these talks and I think, oh, should I do slides? And sometimes I do. And I think, actually, I'm going to go with the flow of how things are talking. And I could just, co-production's been tarnished in some places. Some people don't like the word. They think they've done co-production, that they've had their fingers burnt, when actually they might have been doing some involvement or engagement. And I think that element of actually having people right at the beginning, and even service users, patients, clients, depending on what area you work in, they even say, God, why is it so disorganized? Why NHS England so disorganized? I'm like, no, that's what co-production is, about getting gritty and getting in there right at the beginning. If you're being invited in and you've got a polished piece, then you're just there to rubber stamp that. So I think what's powerful is being in there with the nitty gritty. And sometimes I won't have, I'm not the patient voice, so I see myself in my role as an opportunity to help identify other people, be a person that's highly visible, and definitely within social media. And so therefore, where people reach out, and I will respond as much as possible. So Yulanda, I'm sure I'm going to be in touch with you because I want to hear more about your story. So, and I love it. Whenever I meet somebody new, I think, wow, there's so many people out there doing wonderful work. And then, I'm sure next year will be about us evolving and looking at how we do that. And what's been really important is, so I work for the Experience of Care team, but we've been working with the personalised care group as well. So me, Helen and my team, and Amy Robson, and it's been absolutely amazing to work across and realising that shared decision making is something so important, but something that me and the other members of Lived Experience Group, because we're at that point in our journey where we're able to give back. We were able to be open and we're able to know our limitations. And I think what's really important is not setting people up to fail, to have the people with relevant lived experience, not just bums on seats, I'll say it as it is, but actually people with relevant lived experience who've experienced this stuff, who know what the difficulties are. And it doesn't matter what your background is. I come from, I used to be an IT consultant, but then I worked in the community as a youth worker and play worker. And for me, it doesn't matter where you're from. So health inequalities I really struggle with, because for me it's something that we were doing much way back in community centres. We were doing stuff with co-production, but we didn't call it co-production. So I think a lot of people out there are doing work where they don't even realise that's what they're doing. But having people in, you may have just a small group of patients that you just go to and ask for their advice, but actually if you're going very early on, then it's about discussing their positives, but also what didn't work and how can that evolve. So we could say, do co-production, everyone. It's not going to work everywhere, because we know that everybody has different restraints, and that's what's good, I think, in terms of the role I had. I worked for a trust, and I'm working for a very different type of MSK service, which was working with partners, and we were providers and commissioners. So we were set up a very different way, and I keep on saying that it's great for us to say this will happen, but the reality is contracts. So when I have patients contact me, and I said, but we have to understand there are contracts, and until we have a more consistency or a true dedication from across the board. So I say that on the ground we have people working very, very hard, and lots of patient groups, etc. And with Andy, we're now kind of getting to the point where we're in the middle. So what's really, really important is that we keep the momentum up and realize that actually working together has worked. The change challenge we had, there are people on this call. Hi guys, I know they're on the Lived Experience Group, and doing the thematic review where we had a clinician, a researcher, somebody with lived experience, and it was very, very equal. And I said, if you realize that you're feeling a bit vulnerable, okay, so are they. We're all living this. Nobody's lived this pandemic. We don't know what's happening. So, everybody had that vulnerability, and I think that's what's really important. So for me, it is very much working together. We can, I'm quite happy, and people can reach out afterwards and we can talk about it. But on the ARMA website, you'll see the tweet chat that we did, the themes paper that we put together, the initial blog. I believe the link is on there, the initial blog that the IHI published about how you get a group of people together at speed, basically. And I just went out to the community, picked up the phone, and we had people from, from younger right through to 95. I think that lady was like, don't want to do it on the computer. She did send me an email. She did, and she was zooming all over. But 95-year-old, she used to be in my patient advisory group locally, and just pick up the phone. And if you have to write a letter. You know, there's so many ways to communicate now, or just go to people and say, actually, who's your community champion? So who do you know? Who's that faith leader that's got? Because people have gone out to their faith leaders, they've gone out to their community centres because of what happened during lockdown and how people are feeling. And I think what's really, really important is how we join as a community of people that just want people's health to get better in terms of, and when I say better, I mean, I know I'm not going to get better. You know, my foot's, I've had 3 operations on my ankle. I smashed my talus. For the people out there that know all about taluses, actually, what was amazing for me is going on a Teams call 17 years later and, you know, being opposite my surgeon. That was absolutely shocking. I was like, oh, we were. I was like, you know, I was just like so surprised. So, but that's just, you know, it's been really, really amazing. Chris, how long have I got? 'Cause you know me, I'll talk forever.
Well, I was going to say, well, I love your enthusiasm, and I think everyone here does as well. It's fascinating, you know, particularly with the patient voice. I never want to cut that short. You know, we need, clinicians need to hear that, other patients need to hear that, stakeholders need to hear it as well. I think that's been fantastic. And, you know, some of the things coming out, like you say, across your whole journey, you know, across the lifespan, you can say what, Yulanda as well, you know, you can give a real descriptive, emotive account of what pre-diagnosis was. What was it like around diagnosis? Being diagnosed young, a lot of inflammatory conditions, again, in your, you know, in the formative years, in your 20s, that sort of thing. And also, I think you mentioned there about work and being out of work. As a clinician, you know, we look at things like absenteeism and a thing called producteeism. So how, you know, when you're in work, how, you know, how active are you able to be, and how much does your condition affect you? So I think all these things are very, very important.
Chris, I've never worked so hard in my life. COVID has been amazing, and I've gone full time this summer for the first time in 8 years. 8 years since I've been full time. And that's been because of the support I've had from colleagues. Access to work has helped me. Definitely. You know, I'm here at home working from home, and it's been a blessing for me, to be honest.
Fantastic. And I really, just very quickly, I am in the interest of time. We will run a few minutes over, still have a short break. But, you know, for me as well, I'm very passionate about the physical and the mental health being linked in everyone. And I think, like you say, if you're able to commit to something like this, back in work, things like that, it's all very powerful. We do have a question that I want to give to yourself and Yulanda. I will make a note that Lucy McCarthy, I can see your question, and I think I do need to make a point of that. I think your question was to clinicians, and you were saying here, maybe Andy can, you know, will share my thoughts here, but you're saying that, you know, around clinicians taking responsibility and not relying on patient self-management all the time. You've mentioned people with named long-term conditions who need more support, maybe around massage and hydrotherapy. As a clinician, that is a very valid question, very difficult to answer. Self-management is something that we try and advocate. Sorry, Christina, 1 second. Self-management is certainly something we try and support people to, you know, to understand their condition, to make sure that they can be in control as much as possible of their own condition, you know, because I can have the ins and outs of, you know, immunology linked to a condition, but actually just from me saying, I'm the physio, this is what you need to know, that isn't the case. It's me saying, you know, this is what I understand, what's your experience, how can we link the two? Hydrotherapy is something that is a big question that the services nationwide have been disrupted. And then tools like hands-on things like massage, for instance, or manual therapy. Again, some of those tools I think services sometimes find it hard to be able to deliver those, because oftentimes things like that might need quite a few sessions in close together. And so that's sort of thing that is particularly difficult. But the question, Christina, I can see your hand, but the question I think we want to get across here that was upvoted was, you know, what would your guidance be for those services whose patient population do not want to use the helplines? Is there any question that you would say that those people who don't want to use the helplines, but how do we support those services? Christina, you're
itching to speak. What I didn't mention was the importance of peer support. And so what's really helped for me is we had the Camden it's a patient-led pain support group who have been absolutely amazing and throughout. And it's actually one of the innovations that comes out of Change Challenge if people want to have a look. But I really believe that the patients that are on that group who I've known like last 2 years, who've actually, some of them followed me to NHS England, and are on this call and are on the Lived Experience group, and who've then gone on to do beneficial changes, where I lead the patient carers work stream with David McNally. So it's what's really important is I really want to emphasize that we've had lived experience very much as a golden thread and very much as a trailblazer and something to really kind of be very, very proud of, Andy. It's like, amazing. It gets talked about everywhere. So, and it's been, sustained. So it's not just a, fad for a month or two.
It needs to be sustained. Thank you very much. I think we should close there. There are lots of questions, lots of conversation in the chat, which is brilliant. I think what we should do now is say thank you very much to Andrew, Yulanda and Cristina for that opening section here on the ARMA conference. We do have a few minutes break now before our next session, which is chaired by Amy Robson. So I'm going to pass over to Sue and see what she wants to take controls